Our next and last speaker for this session is Dr. Ann Lynch. Dr. Lynch is an associate professor of ophthalmology, obstetrics and gynecology, and epidemiology at the University of Colorado, where she is the director of ophthalmic epidemiology. I had the pleasure of working with Dr. Lynch when both our universities were on the Maternal Fetal Medicine Units network, and I am delighted to know that as she's moved from the Department of Obstetrics and Gynecology into ophthalmology, she has continued to look at the issues of preterm birth and applying it to retinopathy of prematurity. Her talk today is novel approaches to biomarker discovery for preterm birth and retinopathy of prematurity. Please welcome Dr. Ann Lynch.
I would like to thank the organizing committee for inviting me here today. This is a great honor. I'm really excited about sharing my research with you over the next 20 to 25 minutes. So I'd also like to thank Yasser for that really kind introduction. So we are going to, I have no financial disclosures, but one of my co-investigators, Dr. Naresh Mandava, my chair, is a consultant for SOMAlogic, and we will be talking about the SOMAlogic technology a little later on. So let's get started. So here is an outline for our conversation today. We're going to be talking initially a little bit about inflammatory pathways in preterm birth, moving on to a complement study I did several years ago, looking at the contribution of the complement pathways to preterm birth, and then moving on to talk about the proteomic technology and two of the studies that I've used this technology in, one in preterm birth and one in retinopathy of prematurity. Now, as we have heard and as we all know, preterm birth is a pathological outcome of pregnancy. And to me, it's just affecting way too many babies in our country and also globally. It is a disease with a major public health impact, and we really need to do better. Now, one of the problems with preterm birth is the fact that we have so many causal pathways involved, and some of the previous speakers have touched on this issue as well. Now, several years ago, Dr. Lockwood conceptualized 4 pathways for preterm birth, and I've always liked this slide. It probably has changed a little since then, but it's still a nice slide. And he speaks about stress, inflammation, hemorrhage, thrombosis, and pathological uterine distension, all leading to a final complement pathway, or a final pathway of preterm delivery. Now, the pathway that has really interested me most in the last 10 years, started about 10 years ago, was the inflammation infection pathway. And my specific interest was in the complement pathways. I'm not going to spend a lot of time on this slide because it's kind of complex, but the triggers for the activation of the complement pathway are shown on this slide. Complement is extremely important as being on the forefront of dealing with any kind of infection or inflammation. And it has really become all of these pathways have really become very important in about the last 2 decades. But I just want to concentrate on the area that I worked on, which was the alternative complement pathway. It's at the very bottom of the slide here. And I examined the activation fragment BB, which is a great marker of alternative complement pathway activation. And my idea was to actually look at this in preterm birth. So I've always been interested in just getting in on the natural history of a disease early in the process, just to see, is there something subclinical going on that we're not captivating? So the specific aim of my project was to determine if an elevated level of the complement activation fragment BB in early pregnancy is an independent risk factor for preterm birth later in pregnancy. So what we did back at the University of Colorado, we had a prospective study of 784 women with singleton gestations. And we took a single blood sample. It was just one blood sample at an average age of around 12 weeks gestation. And then we followed these women right through pregnancy to determine their outcomes. And the outcome we were looking at for this particular study was spontaneous preterm birth from either preterm labor or from PPROM. And here are the results. So what we found was that if a woman had an elevated level of BB in early pregnancy, and we're talking about an average again of 12 weeks gestation, she was at a significantly higher risk of having a preterm birth less than 34 weeks gestation as compared to women who had a late preterm birth or a term delivery. And when we categorized this variable, we found that these women were actually, their risk was almost 5 times more than those who had a term delivery. So in summary, for this study, the results suggest that an inflammatory event, and we've heard the other speakers talk a little bit about this earlier on today, linked to activation of complement in early pregnancy, perhaps is associated with the pathogenesis of preterm birth. So this paper was published in 2008, and about 3 years later, I had the unique opportunity of actually going back and addressing this research question again using a different method. So this time we used a proteomic technology. This paper has just been published. So at the heart of the SOMAlogic technology are slow off-rate modified aptamers. And these SOMAmers, as they're called, are single-stranded DNA-based protein affinity reagents with modified side chains, as you see here on this slide, that expands the chemical diversity of the standard aptamers and enhance the specificity and affinity of protein nucleic acid interactions. Now, what I find very appealing about this assay, and I think this will be very appealing to neonatologists in the audience, is the fact that we can measure over 1,000 proteins in only 150 microliters of serum or plasma, and that we have a very dynamic range. So for this study, we did a nested case control, and we went back to my previous study, the Denver complement study, and we used exactly the same samples and the same clinical data. And our specific aims this time were a little more complex. We wanted to perform a discovery analysis and identify circulating proteins associated with preterm birth. Secondly, we then wanted to look at the top-ranked proteins that distinguish cases of preterm birth from term controls. And then we wanted to look at the pathways associated with preterm birth. So we have a lot more going on here with this study, and I have to thank my wonderful statistician, Dr. Brandy Wagner, for helping out with this. We had exclusion criteria this time, and we really concentrated our efforts on women who had a blood sample between 10 and 15 weeks gestation. We just wanted to avoid the whole problem of confounding by gestational age. And the other exclusions are listed here on this slide. We ended up with 41 cases of preterm birth, 22 were spontaneous and 19 were medically indicated, and we had 88 term controls with uncomplicated outcomes. Our statistical analysis, we did a log-based transformation of the protein concentrations. We compared our cases to our controls using logistic regression. We used the false discovery rate for multiple comparisons, and then random forests to multivariately evaluate the proteins. The proteins were then categorized into pathways using the Reactome software. So here are our results, and I think we just need to pause here and just take a little time on this slide. So what you see here on this slide, on the x-axis we have the odds ratio, and on the y we have the p-value. And the line across the middle, sorry I don't have a pointer, is a p-value of 0.02. So what you see are the proteins in red are the proteins that had a high odds ratio for preterm birth, and the proteins in blue are the proteins that had a low odds ratio for preterm birth. And we have just named the most important and the most highly ranked proteins on this slide. So I think you can see that we have 2 coagulation proteins up here that are really distinguished on this graph, which we call a volcano plot. And they had a very high odds ratio for preterm birth. But we also had some proteins related to the complement pathway, notably factor B, factor H, and ficolin 3. And then we also found an elevated level of SAP, which is serum amyloid protein, which also has links with the complement pathway. So we began to see kind of a trend here that complement, was important in this analysis as well. And then on the lower side, on the left-hand side of this volcano plot, we see some proteins like JAG1 and Notch3. And these are proteins that are part of the Notch signaling pathway and may in fact have important roles in maternal-fetal communications in early pregnancy. We then went on to do the random forest analysis, and again we saw a very strong, very similar trend in the results. Similarly, when we did our multiple comparisons, again we saw a similar trend, although we had some attenuation of the p-values, possibly because of the smaller sample size. Then we did the pathway analysis using the reactome, and we found the top 3 pathways were the complement cascade, the immune system, and the coagulation cascade. And important to note when you're doing this analysis that we have a lot of overlap in these pathways. So for instance, a lot of the proteins that you would find in the complement pathway would also be included in the immune system, but we basically put all the p-values together and then ranked them. So in summary, we found those 3 pathways were associated with preterm birth. And then I think importantly, using this unbiased approach, we recognize now that we saw a signaling pathway also for complement in this data set. So we basically validated our first study. And then we found some novel proteins as well associated with preterm birth. So in moving forward, I'm going to move on now and talk about retinopathy of prematurity. So I had been working on the mom side for about 10 years, and then 2 years ago I was recruited into this new position. And within a few days, I was asked by our wonderful group of pediatric ophthalmologists if I would get a research program going on ROP. And so let's just spend a slide talking about what ROP is, because I've really become very passionate about this outcome. It's a vision-threatening proliferative retinopathy of premature and low birth weight babies. And what is important is it's a leading cause of blindness in children. Now, there are some major risk factors, which we all know about. Gestational age, particularly less than 31 weeks gestation, and birth weight less than 1,500 grams. Now, the other factors, of course, that are involved in ROP are exposure to oxygen. All of the neonatologists know all about that. There's a lot of history about that. I'm not going to go into it. It's very interesting. But I think what really interested me was the loss of the maternal-fetal interaction. And we've seen a lot of great papers coming from Dr. Lois Smith and from the group from Sweden, Dr. Hellstrom, looking just at what happens when there's loss of the maternal-fetal interaction because of a preterm birth. And what happens then is you get low insulin growth factors and other factors, and this really contributes to retinopathy of prematurity. So there's some great recent literature about that. Now, through the great efforts of the American Academy of Pediatrics and also of Ophthalmology, we have a great screening program for ROP, and here's a little baby getting an examination. It's kind of hard on the babies, as I think many of you would agree. So what I did for my group to start off and to get them going on their research, I started a registry. And so every baby who is at high risk for ROP at our institution, at either children's or university, they're now included in the registry. And we now have 1,500 babies in the registry between 2006 and present. I'll put the registry together in modules, of course, concentrating initially on the ROP outcome, but now we're adding some additional modules so that we're going to be able to address some more research questions. We have our first paper from our registry from one of our great residents, Dr. Jennifer Cow, and we now know the incidence of ROP in our institution is running for high-grade ROP of 9%, and about 24% of our babies have low-grade ROP, and 67% do not develop ROP. So, of course, my big focus was to try and get a biomarker discovery project going using the proteomic technology. So using this approach, I wanted to identify proteins again early, because I like getting in early on the natural history, early in the neonatal period related to the subsequent development of ROP. Because when we screen these babies, they already have a problem. So I wanted to see, was there anything that we could find with these proteins that would actually predict ROP? I'm not going to go into the definitions of ROP. It's very complicated, but I thought it would be just very interesting for you just to see what ROP looks like. And again, it does not look good. This is a baby who has high-grade ROP. And what you see here is neovascularization at the on this ridge, which separates the vascular from the avascular retina. But you can also see in this fundus photograph that we have some really abnormal blood vessels. They're all dilated and tortuous. And then on the other slide over here, our ophthalmologists have to come and laser the retina in these babies to stop the bleeding and also to cut back on the VEGF production. So this is not an easy procedure either for these babies. So this is a really significant outcome of preterm birth. So to do this study, I needed to identify a preterm birth cohort, a data set that included a sample taken in the first week of the baby's life, and that had the results of the proteomic analysis. And I was really fortunate, and Steve Admel, who is one of our professors of pediatrics, he provided me with a data set. It was really very generous of him. So what we did was we have a great collaboration going with him now. We took his records and then we merged them with the data set from our CO-ROP registry to be able to get all the ROP outcomes. And we applied the exclusion criteria that are on this slide. So in our analytic data set, we had, this is really a pilot study. We had 12 babies who had high-grade ROP and 23 who had no ROP. We applied the same kind of statistics that weren't quite as complicated as what we had done for the preterm birth study. And here are our results. So, again, this is a very similar, this is a volcano plot again, very similar to what I showed you for preterm birth. So again, we have named the proteins on this plot that are highly ranked. You see the odds ratio on the x-axis and the p-value again on the y-axis. In this situation, we actually saw a lot of proteins that were much lower, significantly lower in babies who had high-grade ROP as compared to babies who had no ROP. And I think we had about 16, and then we had 12 proteins that were higher. So in the interest of time, I really can't go into discussing all of these proteins. So I just wanted to pick on some that were kind of a little different. And I think you can see that there's one protein, MnSOD, that really stands out on this graph. And this is superoxide dismutase mitochondrial. I've put some of the names here on the bottom of the slide. And this protein was highly significantly lower in babies who went on to get ROP as compared to the controls. So let's talk about these four proteins: CRDL1, insulin growth factor binding protein 7, and PCSK9, because they're kind of different. And I really do agree with one of the previous speakers that says we just have to start thinking a little outside the box in terms of preterm birth and trying to find something new. So superoxide dismutase is an antioxidant that scavenges oxygen radicals that result from oxidative stress. And we've heard an awful lot about oxidative stress in other diseases such as cancer and cardiovascular disease. Now, this is an extremely important protein because it provides the cell with a powerful defense against the deleterious effects of elevated levels of ROS. We also know that babies, these little preterm babies, are extremely at risk for any kind of cell damage and oxidative stress. But we also know from the ROP literature, and a very nice review from Dr. Elizabeth Hartnett from the University of Utah, that oxidative stress has actually been proposed as a mechanism in ROP. And interestingly, we did find one animal study where an increase in SOD actually ameliorated oxygen-induced retinopathy in transgenic mice. So this is kind of interesting. So our results suggest that low levels of MnSOD may be an early neonatal marker of immaturity of the oxygen defense system that places a baby at risk for ROP. Now, the second protein is called CRDL1. And again, there's not a huge amount in the literature about this protein. It's a bone morphogenic protein 4 antagonist, and probably one of the nicest papers I've seen on this protein actually comes from Dublin, Ireland, from Dr. Kane et al. And in this review, or in her study, she found that this protein was actually upregulated in response to hypoxia. And in that situation, it antagonized the anti-angiogenic effects of BMP4 on endothelial cells. So it actually, in a hypoxic situation, it is pro-angiogenic. So we sort of are postulating that perhaps in the situation where we have low levels of this protein, it may contribute to the anti-angiogenic state that we see in the first phase of ROP. Now, I put up insulin growth factor binding protein 7 because this is, of course, a protein related with links to the insulin growth factor pathway, which is extremely important. We discussed that a little bit earlier on in ROP. And it's always nice when you're doing these kind of proteomic analysis to see some trend with the existing literature. So it was nice to see that we found this protein, although with this particular protein, there's actually very little about it in the literature. But it is downregulated in response to hyperoxia, which again may go with the first phase of ROP. And there are some family studies where they have found mutations of this protein are linked with macroaneurysms and supravalvular pulmonic stenosis, a disease called FAM, suggesting that it has a role in vasculogenesis and angiogenesis. And then the last protein I wanted to talk about was PCSK9. Now, you know, I'd never heard of this protein, but if you show this to someone who works in cardiovascular medicine, they'll know all about it. This is a very, very important protein with links to cardiovascular disease. It was only discovered in 2003, and it is distinguished as a target to reduce low-density lipoprotein cholesterol. So again, an interesting protein with sort of an angiogenic background. It's possible it may have a role in ROP. So our study certainly has some limitations. Our sample size was low, but I feel this is a good start to looking at this question in ROP. We were unable to adjust for multiple comparisons because of the low sample size. And obviously, we would dearly love to have been able to stratify by gestational age, but that just was not possible because of the numbers. So in conclusions, I think our discovery approach with ROP, we found proteins that were novel, MnSOD, CRDL1 and PCSK9. We found proteins with links to establishing signaling pathways for ROP. And lastly, I think the MnSOD story is interesting, and this protein actually may be an interesting target for future therapeutic interventions. Overall summary of the use of this technology, I think it's great that we're able to look at a lot of proteins. With my first complement study, I was just able to look at one protein. And with these other studies, we were able to look at a lot more. And I think, we found some interesting results with both preterm birth and ROP. And these novel proteins may help identify new therapeutic targets, because this is what this is all about, is to try and find some interventions to help with these babies with these really adverse outcomes. So I'd like to thank everyone who funded me over the last 10 years and all my investigators who have helped me again during the last 10 years, from my complement research to my ROP research. And thank you for your attention, and I'm happy to accept any questions.
Thank you, Anne. We have lunch waiting, so we have time for one question.
Well, these are proteins that are just found in the moms. Obviously, the proteins that we looked at in these particular studies are just what's on the current menu. There are many more proteins have been developed since then. In fact, I think the menu is now up to 4,000 proteins, but we were only able to look at about 1,000, just a little over 1,000 proteins. So yeah, a lot of them they're there in the mom. You raise a really good point, though. It's possible with the baby, we may be picking up some of the maternal-fetal interaction with some of the proteins we found with the baby. And obviously, we need to pursue this research further with a much bigger cohort. We just had a very small number of babies in our ROP study, but that's definitely our plan, is to move forward and do a much bigger study. But that's a really good point.